You, sir.
Thank you, Dr. Pachuram, for the wonderful introduction. It's great to be here. I'm happy that the session is being chaired by none other than Dr. Gada. It's a proud privilege for me. Also, I'm very happy to be here in the city of Calcutta, the city which gave India its first IVF baby, gave the world its second IVF baby. So thank you, Dr. Gautam, for inviting me here. And thank you, the entire organizing team. So what I'm going to talk about is abnormal sperm morphology, 100%. Can we get a pregnancy, live birth, normal birth with 100% abnormal sperm? Before 1992, it was not possible. But now after 1992, with the introduction of ICSI, it is now possible to get a normal baby, normal fertilization with even abnormal sperm. So that's the hero of my talk, the sperm. What is he? If you go to see, is the male reproductive cell, the gamete. He is haploid, he's got 23 chromosomes, his length 4.5 to 5 microns, is a width of 3 to 3.5 microns, is a very long tail, 45 microns. Very simple guy, just a head and a tail. And what his function is main is to go to the oocyte, fertilize the egg, and that results in a live birth. But if you take a cross section of him, you will see he's quite a complex character. Not just a head and a tail. You will see it's got a head, a midpiece, a tail, and lots of very structural changes. Lot of structures are there inside. Like in the head, you will see there is the nucleus, covered by acrosomal cap. Each and every part of the sperm is a very important function. The midpiece has mitochondria, the power of the cell. The tail also is very, very important. Without a tail, the sperm cannot reach the oocyte. You can't have fertilization. If you see the cross section also, you will see lower down there is centriole, which plays a very important role in fertilization. I will come to this centriole in detail in my last 2 or 3 slides. If you see the WHO reference from 1980 to the latest one, which is 2020, the 6th edition, if you see the count, motility, there isn't much difference. What was like the count was around 20 million, was more than 20 million was a normal count, say in 1987. And today it is around 15 million. Even the motility, there isn't much change. It was supposed to be around 50 million or 50% motile sperm would be considered normal. Today it is around 40%. Only you will see the significant change is in morphology. Earlier it was like 80% normal forms you need to classify a semen sample as normal. Today it has come down, steadily is coming down from 14%. Today it is just 4%. So just you have 4% of normal sperm and you are classified as a normal male, normal semen analysis. So the importance of, you see, the morphology steadily is decreasing. So what is normal? What is the importance of a normal sperm morphology? When you select a normal sperm, it has got an oval shaped head. It's got a, most important is when you select a normal sperm, it will have a good complement of the DNA, the genetic material, which is very, very important. That is why you select a normal sperm. If you see the Kruger's classification, which many people still apply today, if you have around, say, 14% of normal sperm in a semen sample, the chances of fertility is very high. This is without any ART techniques. When it comes down from 4 to 14%, it is slightly decreased. And below 4%, like 0 through 3, the chances are very bad of conceiving. So just to show you the different normal sperm, different abnormalities, what you see, you will find these abnormalities even in the normal semen sample. You get head defects, you'll have defects in the size of the head, large head, small head, pin head, or different shapes you'll find. Instead of oval, you'll find, sperms like acrosome is missing, like the round head sperm, or very less small acrosomal cap, just around 5 or 10%. You will have tapering forms, lot of variations you'll find. Then when you see the midpiece defects also, you will have a thick midpiece, a bent neck, and finally tail defects. You see the coiled tail or double tail. All these are abnormalities, and chances of these sperm having aneuploidy is very high. Now you see the difference between a normal fertilization and ICSI. Very, very important is the sperm has to reach the oocyte. There's an acrosome reaction which happens. The sperm will go bind to the oocyte, then the acrosome will release the enzymes, the hyaluronidase, acrosin, and then only the nuclear material enters the ooplasm. And the rest of the sperm is outside. But now thanks to ICSI, you can inject the entire sperm in, and very, very important is you have to cut the tail of the sperm here. Only then the oocyte activating factor is released, that PLC zeta, which is released, is present in the acrosome. That is released, and that activates, starts the calcium oscillations, and that entire process of fertilization begins. Many times you will find non-motile sperm you get. like cases, these sperms are alive, like case of immotile cilia syndrome or tail defects or in TISA, PISA. They're all alive, but there is no movement. And other cases, necrospermia, dead sperm. So whenever you find live sperm but with tail defects, all these, the head may be normal. You will have normal morphology of the head morphology, everything will be fine, and this can give you good fertilization. Even so, if you pick up a sperm with coiled tail, if there is no option, the sperm head is normal, you will get good fertilization and good live birth. But only this case like necrospermia, all the sperms are dead, you do not get fertilization. So many times, you use normal sperm, inject it, and then you find recurrent abortions. Then you analyze again, you find there is very high DNA fragmentation. So then you have got options, then what to do. You have to separate the sperm, which is free of DNA fragmentation. You can use density gradient, or latest is microfluidics. Then also there is a repair mechanism, you do ICSI if there is a high DNA fragmentation, because the oocyte can repair the mechanism. This happens in certain cases. We also use testicular sperm if we find very high DNA fragmentation in the ejaculate. And then certain times we can also use advanced sperm selection methods like IMSI and PICSI. Now you can see this particular semen sample we had on the staining, normally we see it at 1,000 times magnification when we see it under the light microscope. You can see the vacuoles in that. When we do ICSI, we are doing it at 200x magnification. So here you can just see the image in that 200x magnification. You can't just identify if there are vacuoles or any defect in the sperm. It just, everything looks normal, you pick it up, inject it. So what we do in such cases, then we magnify them. We have an IMSI system where we magnify the sperm 7,000 times. Here you can see the vacuoles which will be present, and there is many papers, there is a correlation between vacuoles and DNA fragmentation. So whichever sperms have vacuoles, they are supposed to be high in DNA fragmentation. So we avoid this sperm and we'll pick up sperm which are normal. This is one very important paper I got. This has been cited many times. Here in this study is from the Asian Journal of Andrology. This study from 2017, they analyzed 24 men who had 0% normal forms. And it was over a period of 2.5 years. There was no ART done. And 29.2% of these men, they were able to conceive. The wives conceived with these guys' sperms. So very, very important paper. So without ART, you can get natural conception also with patients who had 100% abnormal sperm. Of course, what I think is many times the semen samples had lot of variation. Maybe there were some samples where there were normal forms also, and that may be one of the reasons where you would have got these pregnancies. Other group where they have done ICSI between patients who had 0% normal form and patients who had more than 1% normal forms, and they did not find any difference in fertilization, clinical pregnancy rates, or live births. So the fertilization rates with 0% group was actually higher, almost around 66%, whereas the live birth rate was around 39% in that 0% group, and others were, in that 1%, it was around 46%. So they have said it's not statistically significant, so there isn't much difference. Now when you use one of my old papers we had done when I was in Justlo, I think 25 years back, we used to do a lot of varicocele patients we would get. We'd find a lot of tapering forms. And then this study we had done, patients were operated and all. After surgery, we did a follow-up. And we did find that there was significant improvement. But today, because I go a lot of places with Dr. Rupen Shah and all, so he also advises no need for surgery for this patient. If you find few normal sperms also, those are ones you select and you can use them for ICSI. We have been doing a lot of micro-TISA nowadays. The patients who have repeatedly, they have not found sperm in regular TISA. This is one of the cases we had done. You can just, I had added sperm mobile also, theophylline. Then the sperm starts moving. This took me around 3 or 4 hours. We did find some 10, 15 sperm. You can see the sperm, that guy moving, is completely abnormal. If you do micro-TISA, you will find these are the kind of sperm you see. But these patients strictly don't want any donor sperm. They want only their sperm, and they are all counseled. Okay, so we'll go ahead with this kind of abnormal sperm. And then we were able to get a pregnancy with this. We have started doing freezing this sperm, even though they are abnormal. And this particular case, we reported the first in the country recently. That's a sperm device. You pick up this few sperm, because in micro-TISA, you may just get, sometimes we have 10 oocytes, we don't even find 3 or 4 sperms. Then we freeze the remaining oocytes. But if you get, then it's best is to freeze them, and you can use them later on. Thaw them is not a difficult, very easy procedure. Certain cases where they have very specific defects, like 100%, like a syndrome, 100% abnormal sperm. This is like globosospermia, round head. Of course, it's a very rare case. It just occurs in 0.1% of male infertility. Here there are two types of round head defects. One is 100% round head with acrosome absent. And the second is 80% of round heads. And you will find some sperm. If you go through it, somewhere you will find some normal sperm also. Maybe say 10% or 15% of acrosome will be there. So these are the sperms which can give you good fertilization. You have to select them, pick them up. Whereas round head with acrosome absent, the chances of fertilization are very, very less. They have been repeated, even with ICSI failed fertilization have been reported. The reason being that, like I mentioned, that PLC zeta, which activates the oocyte, that is present in the acrosome. And here, because the acrosome is absent, that is missing. There are now newer techniques which have been done, like you can do artificial oocyte activation. And there have been successful live births, couple of papers I got. One with a Y chromosome microdeletion after ICSI, they were able to get, with 100% rounded, they were able to get normal pregnancy and live birth. Other one they got with artificial oocyte activation. Next is immotile cilia syndrome. Here there is absence of dynein arms, that's why there is no axial filament, no zero movement. But these sperms are all alive, and even I had done a case and we got good pregnancy. So this is not much difficult. Only what we do then, we use hypoosmotic swelling solution. You can't use theophylline, it doesn't move. The dynein arms are absent, so you can't get any movement. So we use HUS solution, and with that we try to pick up a live sperm. And that is because the head is normal, we get good pregnancies. Of course, these are all rare cases. This is a defect which many of you must also have come across. Stump tail defect, short tails. So many times we then advise the patient, let's go and do the TISA. Majority of times I have seen like this is like genetic, even in the testicular sample, we have found short tails only. And we have then used those tails from the sperm from the TISA, and we have been able to get pregnancy. Otherwise, naturally, there is no way, only with ICSI you can get. Because the sperms can't reach the egg, there is no fertilization which is going to occur. There is another case what I found in one of the literature studies. There is a neck defect at the junction. This is like once, I think many years back, I had gone to one of the workshops. I was doing a ICSI, and I was facing this problem. It happens when you're trying to cut the tail would get detached from the head. And it was very, very difficult. I was continuous, for that time, I think I picked up 40, 50 sperms I was just doing, and then the people on the other side, I was in the lab, they were telling me, what is the problem? Why are you not injecting? Because that time they were actual patients' eggs which I was supposed to inject. So I said, no. And the thing is, if you inject these sperms with just the head, and it's detached, there is no fertilization. Because centriole, which plays a very, very important role in fertilization, it remains in the principal piece. It doesn't remain in the head. So if it is detached, do not use those sperm. Try to cut more sperms and inject a sperm where the centriole will be there along with the sperm head. Just some of the defects, very rare defects, like one is just a head, mostly they are atratic, you won't get fertilization. And there is very important to differentiate between a pinhead and a headless sperm. Headless sperm, there is no head at all, no genetic material, so these will never fertilize. And there is another category, pinhead, just a very tiny speck of genetic material, we call it pinhead. You may or may not get fertilization. Most of the cases, there is no fertilization. But this, because sir is here, I would just like to mention this case. I had in Kenya many years back, there was this couple who was a doctor couple, they had come, and I saw the sample I was to do ICSI, we had around 20 oocytes. It turned out to be all pinheads. So I told the doctors that it is just not possible, you won't, because all the literature we have been reading said you will not get. But a doctor knew about it, he said, no, whatever it is, just go ahead and inject with that. Otherwise, then maybe next cycle we'll think of donor, so I injected. I was trying to select, where I can see something, some head or something, injected some 20 oocytes. Next day, then I found around 7 or 8 fertilized. Even I was surprised, and good embryos. And then we transferred, but this was in Kenya, so there was no follow-up. Now I mentioned sir's name because then after a couple of years, I met Dr. Gada's embryologist, Dr. Virendra Shah. He mentioned to me, this turned out to be one of his close relatives. So he told me that patient conceived, that pinhead, and especially he said, I wanted to tell you about that case, and that doctor even, he had read the literature, there is no chance of getting a pregnancy. They even did a DNA testing and all, and they found it was their own. So he told me, Dr. Virendra Shah, about this case, that it was his relative, and there was a beautiful girl, baby girl born. And now, if you see the WHO, then all these pinheads, headless sperm, tailless, they are not an intact sperm. So they do not classify this as a sperm abnormality. So finally, I'll just come to the conclusion. If you see this ASRM, reproductive facts and all, which is online, there are so many questions which the patients ask, can an abnormal shaped sperm fertilize an egg? The answer is yes, it can fertilize an egg. Then the next concern is, what about genetic abnormalities being transmitted from to the offspring? There is always a chance, even when you use abnormal sperm, the chances are higher. Then you will have to counsel the patient, inform the patient, these are the possibilities, and you do PGTA, you can do genetic testing and all. And finally, so why is sperm morphology, should it be taken seriously? Is it really very important? Very, very important. As far as possible, try to select the most normal sperm. It will take you longer time, but select a motile sperm, normal sperm, you will find. Normal head is most important. And because what we want finally, we just don't want to achieve a live birth. We want to achieve a normal birth without any birth defects. Thank you for your patience.